So the first question I want to ask today, we've asked for the last 4 years, is I'd like to start with Professor Saylor. Is cross-linking...
Come on, the opponent first.
Opponent, yeah. No, the question is not for the opponent, it's for the person who started it. Is it cross-linking for all today, after 20 years? You can come here,
I'm cross-linking everybody.
Well, we are.
Well, you can sit down.
In all patients?
Yes.
Should we be cross-linking all our patients? Yeah.
Of course not. Come on. That is a medical tool that we inaugurated 30 years ago, and as every therapeutic tool, it has its indications and contraindications. And therefore, it's not good for everyone.
But Damien says it's not for anyone. You stop rubbing, it does everything, it does wonderfully well. It does work like cross-linking.
So why don't you ask him about that?
Yeah, let him come and speak.
So cross-linking in all doesn't mean that all are in cross-linking but me, no?
We have a question which a lot of people have asked me about this. Forget the debate part of it. Have you done cross-linking in your life for anybody?
No.
You've never done a cross-link in your life. You're a cornea refractive surgeon. Never?
Never.
If somebody comes to you and says that I want cross-linking, what do you do? Does your fellows do it?
I say you can do it, you can take a second opinion. Sometimes I usually refer my patients to other doctors so they can have an opinion. But in my logic of events, I wouldn't do cross-linking for the reason that, my vision on keratin.
Sorry, I think you both can sit down if there's an echo. No, not them. You can come here, please.
No, I was trying to listen.
Oh, I'm sorry.
We're getting the echo.
It's not the reading. He is deaf. He can see.
It's a French accent, maybe.
It's Brexit. You see, I'm getting away from these Europeans.
So, yes, I was saying that...
No, I asked the question, so you don't do cross-linking at all in your hospital?
Because I wouldn't really do something which I consider a wrong answer to a disease which is not understood the way it should be. In my humble view, keratoconus is a traumatic disease. It's almost like a sprained ankle, but the sprained ankle happens in like half a second, whereas it takes years of rubbing to get that deformation. So even if the cross-linking would succeed in making the cornea stiffer, which I doubt because clinically there's no evidence of that, I wouldn't do it still because the force that people exert on their cornea is so strong in terms of Newton, for example. It's like 10.
I have a question for you.
So I wouldn't do it. No,
so we believe about the rubbing. What if a patient, if he's not done cross-linking, and he develops a progression, and he sues you, saying that you did not give me a standard of care. Even now it's an FDA-approved procedure because you don't believe in it. What do you do for that?
No, I must tell you also that I don't believe keratoconus to be an ectatic disease because we didn't measure any ectasia by measuring the surface of the cornea. So it's more like a warpage or a deformation. When it progresses, in my experience with my patients, it's usually because, all the time, people, they admit that they rub. For example, I have a patient who progresses in one eye and who's stable in the other eye. He says, this eye is for vision, this eye is for being rubbed because I like to rub this eye. And
just 1 minute, he wants to comment on this. This is a debate.
So now I would say one good indication for cross-linking to me is that when people get it, they tend to stop the rubbing because for many reasons. First, they got an operation in the eye, so they're like, I'm not going to touch that eye. Second, they have a desensitization. The cornea gets, the nerves, fiber get altered, and there's less irritation, so they are not that much triggered for the rubbing.
So you believe it's not necessary at all, not even for anybody?
I would say if the patient stops the rubbing, it's not necessary, and I tell you this because I would be having a lot of problems in France if the patient to who I tell and explain that they must stop rubbing would progress despite the fact that they stop. All the patients who stop, they don't progress, and we have a website, it's called defeatkeratoconus.com, where we have put those cases because I'm really fully aware that you have not
Professor Marshall
believe
looks
me
very,
right away,
very
but you can
surprised.
check that.
You want to answer first?
I'm sorry, I'm always surprised at what happens in France.
Don't be afraid, it's just me.
Are you seriously saying that you don't cross-link anyone?
I'm serious and I explain why, that's the thing. And if you disagree with me, then give me like sound arguments why I should do it, because in the literature, everything I see is not proving the first, cross-linking is aimed at stiffening the cornea. If I would read papers which would show that the cornea stiffens, not flattens, because flattening to me is epithelial, it happens 6 months later, so it's more like a wound healing response, because if there was a real cross-linking effect, you would see right away. When you go to the dentist, he's cross-linking your
Maybe in 1 minute. Yes.
I mean, I would like to address his concerns in a way that we do have patients that have been parents of adolescent patients were triggered even to give them capsules overnight so they cannot rub anymore, and still it progressed. Then what do you do in those cases?
How can they progress?
We measured it. That it progressed.
Because eye rubbing is not the cause of keratoconus.
I accept
That's
your that.
So,
please,
we have a-
wait. Let us fight now. I mean, this is not right. If I am doing my very best to stop rubbing, and the keratoconus still progresses, little Jonas from Innerschwitz was such a patient. Shall I wait until I have to do a keratoplasty? Because I'm not a believer in crosslink. Shall I wait?
I would wait, and I would again investigate with the patient the possibility that at night he rubs or during the day, because how can you make sure? No, but he's not wearing the capsule all day long.
So if
He was wearing glasses all day long, and he was using capsules overnight, and he stopped rubbing, according to the parents, most of the time. Whenever they saw him, he did not rub anymore, and he progressed anyway.
Okay.
So let me ask a question. Let's assume that the only benefit of cross-linking, the only benefit is corneal desensitization.
Yeah.
Let's say that's the only thing.
Yeah.
Then would you not say that is an effective treatment for keratoconus because it reduces eye rubbing? And what else reduces the stimulus for eye rubbing anywhere close to the same as cross-linking?
So,
What medicine, what anything does?
So can I just take this answer a little bit more? What you're saying is, when you do a cross-linking, people stop rubbing their eyes because it caused kind of chemical desensitization of...
What I'm saying is that it does desensitize the cornea. I think that most people agree with that.
And you are a believer
And
in cross-linking or not? You are with Damien or the other group?
No, I'm a believer in cross-linking, but I'm saying if we strip that away, if I get on the other side and I say the only thing that I'm sure of is that it desensitizes
Me
the
too.
cornea.
I take the point. I agree with you.
Well, so then it is an effective treatment for keratoconus because it stops the only thing that you think is a factor. So therefore, it is a successful treatment.
But, why do you want to use cross-linking to desensitize the cornea? Why not use some medications? Why not use some drops?
Because there are no drops that desensitize the cornea other than proparacaine or a cane that we can't use. There are no other drops that are effective.
You want to comment on this?
Well, I think Brad is trying to bring rational arguments as to why we should cross-linking even if we are in Damien's mind. In Damien's mind. Thank you. Another element I would like to add is I think we all agree that eye rubbing is a risk factor. Nobody contests.
No, I don't agree with this. It's a cause to me. It's not a risk factor. At least it's the only risk factor which is exerted directly on the cornea. So you should consider this as the cause before you say, okay, it's a risk factor.
It's
like sunburn and UV light, It's not,
you just
UV is not
a
risk factor.
I'm trying to find the lowest common denominator.
To me, in my opinion, that's my opinion, but I must share it with you because if you believe that eye rubbing is a risk factor, I disagree with you. It's a cause. It's the indispensable ingredients. That's where I disagree with most of my
I want
colleagues.
to ask.
let me rephrase. Eye rubbing for everybody but Damien is a risk factor. The question for us is, is it passing a threshold over which once you stop rubbing, it stops progressing, or does it induce something that then gets an automated mechanism and progresses, as Theo mentioned? And all I want to remind all of us, if we look at the facts, you know that famous pyramid of scientific evidence? On the top, you have meta-analysis of randomized controlled trials, then you have randomized controlled trials, then you have cohort studies, then you have case-controlled series, then you have case reports, and in the end, you have opinion papers. Now, if we look at cross-linking, we have more than 2,000 midline entries and a decent number of RCTs and meta-analysis of RCTs. On the other hand, I'm happy to follow you, Damien, if you bring me more than one single opinion paper in the Journal of Keratoconus and ectatic disease. That's simply not enough.
Okay.
And once you convince me, I'm happy to change my rationale. But until then, I think these big debates bring unnecessary attention to a fact that 99.9% of the community agree on.
Does it really matter?
We're missing the psychiatrist.
So, Damien, I have one question. Okay. So, I agree that the eye rubbing is the cause, and person is obsessive eye rubber. In that case, when we treat one eye, and if that eye stops progressing, and if the other eye still continues to progress, so does it mean that person now does not rub one eye, but rubs the other eye? How common would that be, where a person who has habit, all these are habitual things, right? I mean, they do not stop. Like if you have habit of eye rubbing, it does not stop in one eye and then you start rubbing in the other eye. So how does that happen then?
If it happens, you can try the cross-linking in the other eye. If it works in one eye because they stop rubbing consecutively after the cross-linking, just do it in the other eye.
So
If it works
this is
on the
question.
rubbing, it's fine to me.
This is Himamshu's question. Do we always, and this is why I would like to ask
No, but
Professor Saif.
I must stress a point. I know that I'm a single person. It doesn't mean I'm wrong, first. Second, it doesn't mean I'm right either. But second, the point is, in the literature, I mean, I'm for evidence-based medicine. If there's a pill, let's say, which is conceived to make you having less fever, right? And it doesn't work, but it has side effects which may be beneficial when you have a flu. I would be still saying this pill doesn't work for the fever, but it may be good for the headache, etc. But how can we as doctors still not investigate in a technique which in vivo does not produce evidences that it works for the reason it was conceived for, that is stiffening the cornea? That's my point. Is this something which looks for you stupid? If, again, we are doctors, okay? We are not believers. I will believe in cross-linking when it stiffens the cornea. I believe in cross-linking for leather, for tires, for
No,
dentists.
I have a question for you. There must be something like 500 papers already in PubMed which says that it works, and of course there may be some
No,
complications.
in vitro, of
But
course
how
it works.
many papers can you pick up which says that
and it's
you
a
don't
brilliant idea, I
cross-linking,
understand
it doesn't work?
Okay, so I had mentioned earlier I have artificial intelligence, which I do. And I use simplistic analogies, and this is kind of, you're in a circular argument. Let's say you have a bridge. You built a bridge. The bridge cannot handle these massive trucks that now road. So you can either stop the trucks from going, or you can make the bridge stronger. They both work. It doesn't matter what your approach is. The end game is to make it safe. So if you want to have stop rubbing, stop rubbing. If you want to cross-link, cross-link. You want to do them both, do them both. We're never going to know because you're not going to be able to do that study.
So I'll ask you a question. There are 3 American doctors here. I'll ask you, all this, till you got an FDA, your concept of treating keratoconus was exactly like how Dr. Damien said. Stop rubbing the eyes, wait for it to go to whatever stage of progression. Do you think that in the last 2 years, by doing cross-linking, you've changed that to a different level? Because what Damien said is exactly what US was doing.
I'd have to pull myself out of that because I was involved in the trials, and in the gap between the trials, I was referring people to Canada for treatment. So,
If some patient did not want to, there may be a big chunk of them who would probably have not gone for a treatment. that would become exactly what Damien is saying, that they were just managed with very strong strong treatment of stopping the rubbing, but apart from that they did not get anything much, right?
Well, I had a number, unfortunately I had a number of people progress during that, during those periods.
Rohit,
the lack of in vivo evidence is not due to cross-linking, it's due to poor testing modalities. The ORA is one of the worst devices ever in terms of what it was ultimately purported to do. Now, we have 2 publications that show a variety of variables, not CH or CRF, that do change after cross-linking to indicate a stiffening effect. Vinciguerra and colleagues have some of those papers. The Corvus, we've been arguing for 2 days whether or not it's 5% better or 10% better than the ORA. There are, however, numerous papers now that show a stiffening effect. What we do know is that we do have good biomechanical testing ex vivo. And every single test ex vivo shows a tremendous immediate stiffening effect. So it's not truly accurate to say there's no evidence, because the evidence that exists all goes the same direction, all of it.
Yeah, I agree, Brad, but there's a point which is, okay, ORA, Corvis are not perfect, repeatability is low. But anytime I'm doing LASIK or PRK and I measure before and after, these instruments are like tracking, showing a decrease in the...
But post-operative LASIK looks just like keratoconus, and we know that's not correct, right?
Yeah, I don't know. I mean, an instrument is an instrument. It measures, if you have a thermometer, which always show you that the fever goes up, you take a pill, it doesn't go down, and you say, oh, the thermometer doesn't work. Well, to me, it's not really something I would take as a first hypothesis.
Right, but what I'm saying is there is evidence based on those faulty devices. There is evidence. There are papers that show stiffening impact. There are.
Professor Saylor, anything you want to add on this question? We move to the next one.
Would you convinced if we would do a Brion spectroscopy measurement in vivo and showing stiffening?
You know, I have a colleague in France. You know,
yes or no?
You know Professor Touboul in France, in Bordeaux. He's a Colin's pupil, let's say. Yeah. And he has brilliant technique, and he knows very well biomechanics. What he told me at SFO last week is that when they measure pre and post cross-linking with Bruggen microscopy, they don't track any stiffening, and the parameters he's measuring now are more or less suggesting that cross-linking would make the cornea like softer. That's what he says.
Yeah.
So, I don't know.
He is giving a paper on this afternoon.
I know.
It's absolutely sure that you get softening because you hydrate the cornea right after cross-linking. But in the long-term follow-up, it's increasing.
But how can it? Oh, that's a good point. So,
4 years.
Professor Seiler, with all the respect I owe you, how can you explain to me that the cornea gets stiffer when the procedure is finished because covalent bonds cannot create themselves?
I have no explanation for that, but it is. No, but you don't have an explanation at all. Come on, I have no explanation.
I don't need an
long-term
explanation.
follow-up is increasing,
but
you have no explanation at all. Come on.
It's not that I have no explanation. I have no evidences. So I'm looking for explanations.
Enough for me.
Rohit, to avoid the real fight, he believes in rubbing, so perhaps he should have boxing gloves so he can't rub properly and doesn't hit Teo so hard.
Rohit, just to add to that, this question that you put up
there. This is something question all of us should look back and then try to answer.
I wanted to add to that and, maybe be his advocate amongst this whole audience and this whole group. I have, and you know about it, we've shared 2-3 patients where we had documented progression in both eyes. We advise cross-linking in both eyes, like documented progression over say 6 months or 1 year, and advise cross-linking in both eyes. Treated the first eye, which was the worst eye. We have now 3 patients who were lost to follow-up after the first eye was cross-linked. They come back after a year or year and a half, and the fellow eye, which had documented progression, was not treated, has gone on to show the progression has stopped, and they've even shown some flattening. Okay, so I shared those cases with Rohit actually, and we have those documented on topographies and everything. So what I feel is that, I mean, I'm just adding to the discussion over here. What we probably think happened is that after the first eye was cross-linked, the patient got so nicely sensitized to his, probably the, the cause of the rubbing was treated, the allergy was treated so well, and then the patient is sensitized that, he's already had to undergo a treatment in one eye, became so careful about, not having to touch the other eye stopped progression, and it actually went down to flatten. And we have now 3 documented patients like that. So how does that figure? I mean,
This
Nobody
same thing-
contests that.
Pardon?
Nobody, I think, speaks against your opinion. We cross-link when there's progression. Fine if you don't see any progression for the time being, but progression never is linear. You might have episodes in the life of a patient where the K readings are flat, and you might have a certain variation of how much of a flattening are you talking about.
This case, I'll just give you background. I'll start with the history. He's not an eye rubber. There's absolutely no rubbing. Progression. We did the cross-linking in one eye, the right eye, and the left eye, the vision, cylinder, everything started flattening. And this, I have a repeatability of this machine, so it's not that one time we did one scan. The Paki is the same. So how do you explain? This is a question which a lot of people ask. I do one eye cross-linking. The other eye, I tell my patient that the other eye will also require cross-linking, and there's no eye rubbing at all. We asked specifically for it, and the question is, even the lubricants, whatever they use for 3 months, then they stop, and over time, you can see that they start showing a state of flattening. And this is not a cross-linked eye. Why do you think it happens? We have an explanation, but I want to listen to yours.
Let's take it to a bigger level. We have to put it into dimension here. We speak about 3 unpublished case reports, and anything is possible in medicine. We will always find the 2 or 3 cases that defy the purpose, that speak against the current dogma. But we cannot put these as equal up on a big screen, whereas we have more than 2,000 papers in Medline that cite the opposite. I'm happy to follow a new dogma, but establish the dogma first. Bring me more than an opinion paper. Come back here next year with evidence, and I will follow the evidence. But I don't want to plot one single picture here of a single case.
This is not debate. This is just a science which I want to ask.
Rohit, one thing I would like to come here. So I have similar patients where I have not done anything, and they show flattening in both eyes. So it's not just one eye cross-linking which is helping other eye. Natural history-wise, there are cases where this progression stops, and as Farhad was saying, that collagen turnover takes place. It's possible that it may show little flattening, and I have patients where I have not operated, and both eyes, they show flattening.
But Himanshu, what happens is, when you see a stabilization, it means that disease is stabilizing. We see some small dioptric flattening. But the 2 or 3 cases I have here, other eye, are flattening by more than a diopter.
That's what I'm talking about. I'm not talking about the test retest variability. In fact, I have cases where on the same day when you are doing a test, maybe 30 seconds apart, you have a diopter or half change on topography. Now that's test retest variability. I'm not talking about that. I'm talking about when it's long term and it's still showing change in both eyes.